So this was, I don't know how you feel about it, but this was a terribly humbling first part of the session where we really realized how little progress we have done despite huge progress at the same time. I mean, one part of the story you didn't say is that 30 years ago I was at the NIH doing a PhD in immunology and looking at immune tolerance. And we really had the same type of discussions with way less knowledge at the time. At that time, we were talking about interferon gamma and TIL cells and IL-2, but that was it. And at that time, we were already extremely frustrated, and we're 30 years later. And with much more understanding, we realize we know way less than what we thought we knew. So we're looking forward. This is very exciting stuff, but we need to be very humble about what we think we know. With that in mind, we're going to change gears completely from a very scientific two presentations to what we as a society, as a community of practice, as a collaborative entity with all of us together here in Canada, which is very different than what I've witnessed around the world or in other societies, have been able to achieve by working together over some subjects. And just over the last year, I'm just going to show you what we have achieved in the BRCA world, in ovarian cancer. So these are my conflicts of interest. They don't really influence me, but I need to acknowledge them. And by the end of this session, what I would like you to know is exactly what we have achieved as a society together. What all of us have done for all of us. And the communities of practice here, you have all of our, again, I can't really go to this side, so I'm sorry. All of the communities of practice, which are basically subjects that we treat and study, a way of our members to be involved in national studies. And you are all very welcome to join, and not only welcome, but we want you to join in those projects. And you can see there are a lot of projects going from nursing to international women's health, to minimally invasive surgery, to BRCA, cervical cancer, all kinds of stuff. So there's really, and if you have an idea, we'll add it on as a project that we as a society are going to support together, which, like I said before, are collaborators in industry. And what I would like to focus on today, there are a few communities of practice that are very active, and mainly we're going to be talking about the BRCA community of practice and what we have done over the last year in that arena, together with a few other ones. So this starts with two basic meetings we had, one in September and one in November. And I'll start out with the September meeting, which was basically BRCA TOT. TOT stands for basically testing to treatment. And what we wanted is to have a complete the complete roadmap of BRCA. And then the next part will be 2 months later, we had a meeting again where we flushed out those things, and I'll present you what came out of that. So at the September meeting, with kind of under the leadership of Michael, who has a vision of the future, he's really drawn by the future rather than being pushed by the past. And with his vision and his strategy, what we did is for the first time bring in all kinds of stakeholders from all areas that are interested in BRCA. And these include, as you can see on the slide, medical and GYN oncologists, molecular geneticists, medical geneticists, genetic counselor, pathologists, patient advocates, and our industry collaborators. So there was really bringing everybody who's interested in the space of BRCA together to try to approach it in a rational way. The goals of that meeting was really to create that consortium, to have an aligned vision and a goal. And a goal is really a dream with deadlines. So we had a dream of going into the BRCA arena. We put ourselves some clear deadlines, and that became our goal. We were going to define the exact roadmap to achieve those goals, and at the same time also interact and network with people from other societies, so we would be able to have an influence on the whole space. So what did we find out about PARP inhibitors? What we said is we clearly want PARP inhibitors. We understand the costs are high, that in view of that, the optimal strategy is to use them in a maintenance setting at the time of recurrence, that when we looked at all the PARP inhibitors, and that's a job that Paul did, basically there is really no difference between one PARP inhibitor and another in function of toxicity or in function of efficiency. And we wanted also to have not only them as a maintenance therapy, but have the option to give them as a single agent in late recurrences, based on the study of Bella Kaufman in Israel. This has led to two white papers, position papers, and the first one is, and it's just finished, is we finished that recently, is a position statement of GOC together with all the stakeholders that were present, that about the use of PARP inhibitors in high-grade ovarian cancer. This is kind of the summary of it. It's large benefit. It's mostly helpful in patients that we can establish BRCA mutation, but not only in them. It's very helpful as a continuation therapy. I don't like so much the notion of maintenance. It's really therapy. We give those patients treatment. We need to give it as recommended by Health Canada, and it might also have value, like we said, on their own and not currently approved. So that white paper is now on the website. It is available. That was the first outcome of that meeting. And a second one was that campaign that, again, Paul had the vision, which is called No Woman Left Behind. And the idea is that every woman in Canada should be BRCA tested once she has a diagnosis of a high-grade ovarian cancer. And that position statement also just came out, where it says, you can see in yellow, GOC strongly recommends universal germline BRCA testing as part of a normal ovarian cancer pathway. So every woman should have that. We know at this point it's about 30% of women who get that, and extremely variable in function of where you are in the country. We need to make sure that it becomes widespread, and we need for that the technology, the infrastructure, but also that pathway, so that it is that we don't lose any women that fall between the cracks, and knowing that for the moment most eligible women don't get tested. So that came out as a white paper also. We felt, and maybe our genetic counselors helped us with that, where we need a patient information booklet. It's very nice that we as a society or as doctors decide this is needed, but the patient needs to be aware of that need. So there is a patient information booklet that is now written. That's the third product of this, together with, in association with the genetic counselors. And it's being paginated now, and you will see it at your doorsteps very soon. There are two other products that are in the works. One is a booklet for the healthcare professionals, and the idea is to also have it as an app on your phone, where it will give you all the information that you need, and as well as a booklet that will give you all of the adverse event and how to take care of adverse event induced by a PARP inhibitor. And again, we would like to have it as an app, so you would have it with you every time you are taking care of patients, or anybody in your team, any healthcare professional in your team. So that's kind of that first part of September and the outcomes of that. And then in November, we stabilized those things, and we looked at a few other things. And the first one was a part of where the trend is about nodes. And I know Michael doesn't like to hear about nodes anymore, but the way to get away from nodes is to go through that passage of sentinel nodes. And I would like to appreciate what Marie Plante said about radical trachelectomy, which really is was a great vision, is radical trachelectomy is a way to go from radical hysterectomy to normal hysterectomy. It's a necessary transition point, which now she's proving with the CX5 study. So this, again, I think sentinel nodes is not the ultimate outcome of where nodes will go with endometrial cancer, but it's a necessary step to get rid of node assessment, and a way less aggressive way to do it for patients. So again, we finished that position statement on nodes, and I hope that on sentinel nodes, and I hope it will help those people across the country who don't have access to do sentinel nodes to go to their administration and say, you know, there is a statement. This is state of the art. You need to help us get this. And the summary statement here is, we all know what a sentinel node is. It is most likely to contain metastases. Actually, in the studies, what we found is that in 40% of the positive node, the sentinel node is the only node that's positive. So if you missed it, you can take out 30 nodes. If you miss that one sentinel node, then basically your lymphadenectomy was for nothing. Or if the pathologist, by looking at 30 nodes, misses that one that really has the metastases, you haven't done anything. So you're much better off taking that one node that's important than 30 nodes that are completely irrelevant. There is another project that is just kick-starting, is the HPV project, the HPV vaccination uptake. There is a big issue is that HPV vaccination happens in schools, and that's not bad in Canada, that has gone well. But a lot of those patients that didn't get that vaccination in schools, how many of those really get vaccinated that could benefit from it? And there is a big project, and there's going to be a first brainstorming session later this year about how to increase the uptake of HPV vaccination in those non-vaccinated ones. And one of the possibilities is colposcopy clinics. We really need to evaluate it because there is a lot of controversial. Yes, John, I'm looking at you. The third one, and I don't know if Marcus is here, I didn't see him yet, is something that Marcus is going to talk to you, and we're going to discuss tomorrow also at the CCTG meeting, and I urge all of you who can come tomorrow morning to come. It's going to be a very interesting session tomorrow. Is based on his data that was a national GOC product also, which was the SHREC, which has led to a few publications on high-grade and high-risk endometrial cancer. And the question he wants to address now as a national study, and he wants everybody involved in that national study, is whether or not patients with early, perhaps serious endometrial cancers should get radiation. We know that chemo seems to be improving outcome. Whether or not addition of radiation helps is what he would like to assess in a national randomized study. So basically that's it. That's a slide that I took from Hal. I kind of liked it. This is a modification of the vision of the GTA area in the middle of Canada. Well, no, I think it's GOC that's in the center of Canada. And we invite you all to join us in the center. Thank you very much.
Well, we definitely have time for questions, or not.
Great.
That's awesome. Thank you very much.